Thank you so much for coming to this webinar, and just so you know, it is being recorded and we will be able to get the slides to you, so don't feel like you need to take all of the notes all of the time. This is the first part of our 6-part webinar series regarding the end of the COVID public health emergency. Today we'll be talking about telehealth, but make sure you sign up for our other webinars over the next few weeks about Medicaid updates, licensure impacts, payment for COVID testing and treatment, employers and COVID, and then finally on May 10th, we'll be doing a PHE recap and general Q&A session. My name is Ashley Watson, and I am a healthcare attorney in the Columbus office of BMD, if you don't know me already. BMD is a mid-sized law firm with several offices in Ohio, Florida, and Arizona. I practice specifically in the healthcare regulatory and compliance space, as well as some healthcare policy and child welfare. Like I said, today we're focusing on the impact of the end of the PHE on telehealth. This is a really important topic for a lot of providers, both here in Ohio and nationally. So hopefully I can answer some of your questions. I will be looking at the Q&A at the end of the presentation, but if you have questions that are really specific to your organization, then please feel free to email me. I'll have my email at the end of the presentation as well. All right. First, we have a standard disclaimer. Of course, I am a lawyer, but I may not be your lawyer. So if you have any questions after the presentation, please reach out to me or your own legal counsel to receive advice specific to you and your organization. As you all already know, telehealth uses electronic information and telecommunications technologies to support and promote long-distance clinical healthcare. Telemedicine is a narrower form of telehealth that allows practitioners to remotely provide diagnostic, treatment, and monitoring services to patients. Telehealth and telemedicine were absolutely critical to the treatment of patients during the COVID-19 public health emergency, and this led to a very rapid expansion of telehealth and telemedicine laws. The reason, of course, that you are listening to this webinar today is because the Biden administration plans to end the public health emergency on May 11th, 2023. That date is very quickly approaching, so I'm sure you're wondering how that will affect your practices. Significant expansions and changes to telehealth occurred during the public health emergency, and many providers are rightfully worried about how the end of the PHE will impact those flexibilities. However, the Consolidated Appropriations Act of 2023, which we're going to call the CAA for short, and other state and federal rules will extend many Medicare telehealth flexibilities authorized during the PHE. And I also have Sarah here monitoring, so if she sees any Q&As that are like, help, I can't hear you, or something is going terribly wrong, then Sarah, please feel free to pull yourself off microphone and let me know. So pre-pandemic, before the pandemic, low reimbursement rates, potential patient privacy violations, and malpractice concerns prevented many providers from using virtual patient visits using telehealth technology. Of course, you're familiar with this. CMS had a very limited view of the types of telehealth services Medicare covered and viewed telehealth as a means for rural beneficiaries to access care rather than as far-reaching clinical tools. Private payers also followed suit in many spaces. CMS and other payers required a patient to travel to local facilities for virtual appointments with a treating or consulting physician located at a distant site instead of receiving the telehealth services at home. Of course, that created a problem during COVID-19 when we had a lot of patients who could not travel because they were sick and contagious. So there may be something there that you need to pay attention to. Okay, so COVID-19 required an unprecedented response from federal regulations to expand telehealth services to protect patients and providers. Just some background there. So starting on January 30th, 2023, when the Biden administration announced it would end the PHE, there was widespread fear about what would happen to these flexibilities. PHE was in place for over 3 years, which granted plenty of time for telehealth providers to kind of establish themselves in the field and establish their rates of reimbursement and get used to these sorts of treatments. If you're a provider, depending on these waivers for PHE, then you should definitely be taking steps now to make sure that you can stay in compliance. And I see a lot of Q&A, so I'm just going to check on it real quick. Okay, so this is going to be a pretty general overview. We have a lot of Medicare that we're going to talk about, and then some Ohio Medicaid. Like I said, we will send the slides, so if you have a very specific question or very specific practice, then that's something that we could talk about separately as well. Okay, so let's see. I'm going to skip over those Q&As. Don't think they're important. Okay, so we have some key dates for the continued expansion of telehealth. Right now, the most important dates to keep in mind are May 11th, 2023, when the public health emergency ends, and then also December 31st, 2023, when a bunch of other flexibilities will end that we will talk about, and then also December 31st, 2024, when a majority of the telehealth flexibilities will expire that were implemented under the CAA. One important resource that I want to make sure that everyone is aware of is the CMS Waivers and Flexibilities website, which is www.cms.gov/coronavirus-waivers. Pretty easy to find via Google. CMS is often updating informational sheets that are organized by provider type and waiver type, so if you have specific questions, that's a great place to go. CMS has also recently posted a summary of waivers that apply by payer after the PHE. So that's kind of what we've summarized here. For Medicare, numerous telehealth flexibilities were extended by the CAA until December 31st, 2024. We'll be talking about those in detail, but just to give you a little heads up, that includes, instead of being restricted to rural areas, people with Medicare can get telehealth services anywhere in the country. Medicare recipients do not need to leave their homes for covered telehealth appointments and can avoid going to healthcare facilities. And if someone cannot use audio and video, like a smartphone or a computer, certain telehealth visits can be given audio only. And again, those will expire at the end of 2024. For Medicare Advantage, your Medicare Advantage plans may offer additional telehealth benefits. These are plan specific, and providers and patients will need to inquire about your telehealth coverage. Usually we can find those plans if you have questions about specific ones. In addition, some accountable care organizations may provide telehealth services beyond December 31st, 2024, when all of the Medicare flexibilities expire, which will enable primary care clinicians to treat patients regardless of where they live. Okay, Medicaid and CHIP. Telehealth flexibility for Medicaid and CHIP is not dependent on the expiration of the PHE and was available through several state Medicaid programs well before the pandemic. In the end, coverage will differ by state. We'll talk a little bit about Ohio towards the end of this presentation. CMS is urging states to keep providing Medicaid and CHIP coverage, even for telehealth services. And for private plans, private health insurance, after the public health emergency, private insurance plans will differ in their telehealth and other remote care service coverage, just like they do now. Private insurance may require cost sharing, prior authorization, or different types of medical management for telehealth and other remote care services when those are covered. So let's dive into some of the Medicare flexibilities. We have some key changes that are going to expand flexibilities past our May 11th end of the PHE deadline. The Consolidated Appropriations Act of 2023 was key in reassuring providers that many of the COVID telehealth flexibilities would be extended through at least the end of 2024. So these flexibilities will last until December 31st, 2024 for Medicare beneficiaries, which hopefully means that your Medicare Advantage plans and other private payers will follow suit as well. So let's run through all of those flexibilities. First, we are extending reimbursement for some audio-only telehealth services through the end of 2024, expanding the definition of originating and geographic sites to include anywhere the patient is located, including the patient's home. This should be a significant help for patients who are too sick to attend appointments or who do not have reliable transportation. Allowing the use of telehealth to satisfy the face-to-face encounter requirement for recertification for hospice care. This is also very important because we have many patients who are very sick in that setting. Providing for a study on telehealth and Medicare program integrity. This one might not seem very important, but it's a really great sign because hopefully it will result in permanent changes to telehealth with proven good outcomes. So hopefully we can see these flexibilities expanded even further. Also, our CAA flexibilities extended the safe harbor exceptions under health savings accounts eligible, or health saving account eligible and high deductible health plans for telehealth services. Also, the acute hospital care at home program may continue to provide hospital services to patients in their homes using telehealth. This program was very important during the PHE because it allowed similar services as those administered during inpatient visits, like physician visits and monitoring, drug prescriptions, nursing services, and diagnostics, to be provided in a different setting. There is a lot of advocacy about making this program permanent, but right now it is still set to expire on December 31st, 2024. So if you have a lot of providers providing that service, or if you've set that up as something that your business relies upon, then just know, get out there and advocate for an extended program, but right now it is set to end at the end of 2024. Continuing with some of the CAA changes that will extend through December 31st, 2024, FQHCs, federally qualified health centers, and rural health centers may provide telehealth services to Medicare beneficiaries instead of being limited to being an originating site for a provider for telehealth. So in other words, prior to the PHE, FQHCs and RHCs were only originating sites. They could not be distant site providers for telehealth, which didn't really make sense for a lot of their patients. So now we have an extension where FQHCs and RHCs can still be a distant site provider rather than limited to the beneficiary's location. Medicare patients can receive telehealth services authorized in the 23 Medicare physician fee schedule in their home through 2024. Also, there is no geographic restriction for originating site for non-behavioral mental health telehealth services. So that means that originating site can be the patient's home or any other location for your non-behavioral health services. That goes through the end of 2024. And it's important to note the non-behavioral health services in this going through 2024, because we'll talk about permanent changes to Medicare later, and that's where we'll talk about the behavioral and mental telehealth services. Additionally, the in-person visit requirement within 6 months of an initial behavioral, mental, or telehealth service is not going to be required through at least 2024. A little bit of background on this one, because it's very important to a lot of providers who created behavioral health practices using telehealth during the PHE. In 2020, Congress imposed new conditions on telemental health coverage under Medicare, creating an in-person exam requirement alongside coverage of telemental health services when the patient is located at home. So if you have a patient at home that you want to provide telemental health services to. Under that rule, Medicare will cover a telehealth service delivered while the patient is located at home, as long as the practitioner conducts an in-person exam of the patient within the 6 months before the initial telehealth service. The telehealth service is furnished for purposes of diagnosis, evaluation, or treatment of a mental health disorder, and the practitioner conducts at least one in-person service every 12 months of each follow-up telehealth service. So essentially what Medicare was saying was, you can treat your mental health patients at home via telemental health. However, you need to make sure that you have an in-person visit at least 6 months before the initial telehealth service, and then you have to have annual visits thereafter. So that rule was originally scheduled to take effect the day after the PHE expires, but then it was pushed back and then pushed back again. So now that rule does not apply until December 31st, 2024. And perhaps Medicare will change the rules so that it will not apply ever after that, but that will take some advocacy. And also, finally, for the CAA flexibilities, telehealth services can be provided by a physical therapist, occupational therapist, speech-language pathologist, or audiologist. So that is great news for those types of providers that want to keep providing services via telehealth to their Medicare patients through at least the end of 2024. In the next few slides, we're going to switch a little bit and talk about rules that are extended past the PHE, but not as long as the CAA rules were. During the PHE, CMS instituted higher reimbursements for telehealth services at non-facilities, like if at a patient's home. This is known as payment parity between your telehealth services and your regular services, inpatient services. Reimbursement parity for services performed via telehealth that typically would have been performed in person will end on December 31st, 2023. So that's an important date to note. More is expected to be known when CMS releases its annual physician fee schedule for 2024, and that is supposed to be released in November-ish. So keep a lookout for that, because it is very possible that these payment parities could extend further than the end of 2023. Right now, about half of the states have passed payment parity laws. So for Medicaid or, state insurance payors, the payors have to pay the same amount for telehealth services that they would for the in-person services. In the other half of states, commercial plans vary widely regarding on what they will cover and the rate at which they will reimburse. So it's another area. There's a lot of advocacy going on around a lot of these. So if you have any questions about who you can get involved with or who you need to send letters to make sure that these payments continue to expand, then that's a great thing that we can help with as well. Always a good idea to contact your legislators if these are negatively affecting you. In addition to the other PHE waivers, CMS temporarily changed the direct supervision rules, and this is a big deal in hospitals or facilities that use a lot of billing under different professionals' NPIs. So under Medicare Part B, certain types of services like diagnostic tests, services incident to, physicians or practitioners' professional services must be furnished under the direct supervision of a physician or a practitioner. For Medicare purposes, direct supervision requires the supervising professional to be physically present in the same office suite as the supervisee and immediately available to furnish assistance and direction through the performance of the procedure. The supervising professional doesn't have to be in the same room necessarily to satisfy that requirement, but the immediate availability requirement means in-person, physical, and not virtual availability. So that is a huge barrier when it comes to providing telehealth services. Among the PHE waivers, CMS temporarily changed the direct supervision rules to allow the supervising professional to be remote and use real-time interactive audio-video technology. That change did not require the professional's real-time presence or live observation of the service via interactive audio-video technology throughout the performance of the procedure. This change was always going to be temporary because CMS was concerned and very publicly concerned about widespread direct supervision through virtual presence and how it may not be safe for some clinical situations, which I think is fairly practical. In the final rule that CMS issued, CMS rejected requests to make virtual direct supervision a permanent feature in Medicare. Therefore, virtual direct supervision will expire at the end of 2023. We don't anticipate this one to change, so make sure that when you are writing your policies or letting your staff know that if they are using direct supervision via some sort of virtual technology, they will not be able to do that anymore past the end of 2023. A few updates now regarding waivers for remote patient monitoring that will end on May 11th at the end of the PHE, so we're slowly getting closer to these deadlines. During the PHE, the OIG stated that they would not subject providers to administrative sanctions for the federal anti-kickback statute or the civil monetary penalty and exclusion laws for reducing or waiving cost-sharing amounts concerning telehealth services or remote patient monitoring for Medicare beneficiaries. So essentially, if you were treating Medicare beneficiaries and you were treating them for telehealth services or remote patient monitoring services, the feds weren't going to come after you if you did not charge the appropriate amount for cost sharing or co-pays. However, after the PHE ends, there is no guidance that is extending this waiver. So that means that after May 11th, providers offering telehealth or remote patient monitoring services to Medicare beneficiaries can no longer reduce or waive any cost sharing obligations. And you need to make sure that you have policies in place so that you either have an exception under the anti-kickback statute. For example, if you have a sliding fee scale or if you have financial policies in place, then that is fine because those will fall under other anti-kickback exceptions. But if you are just relying on this waiver and, not requiring your patients to pay any sort of cost sharing or deductibles, then that is going to become a problem after May 11th. So make sure that you are checking out your policies there. Another topic on remote patient monitoring, it's normally for established patients, pre-PHE for only established patients, but CMS waived the established patient requirement during the PHE. This allowed providers to bill for remote patient monitoring for new patients. When the PHE ends, the waiver will end, and CMS will require the remote patient monitoring services to be provided only to established patients again. So that's another policy change to keep in mind. However, CMS will continue to allow remote patient monitoring services to be furnished to patients with both acute and chronic conditions. And that is a change from pre-PHE when you could not provide both of those. Okay, so we've,
Ashley,
yeah,
I'm sorry to interrupt. You have a few
Yeah.
questions in there. I didn't know if you wanted
Sure.
to answer them now or wait.
Okay, sure. I will look and see. Let's see. Yes, so we will get to prescribing in a few slides. There's a question about prescribing. We will talk about that. And I think several of these we will get to a little bit later. Yes. Is there a single resource that captures each state's telehealth or parity laws? Not really, unfortunately. There are websites out there that kind of compile them, but the problem is they're changing quickly. So there's not a great resource for that, at least right now, but I will keep an eye out, and that's something that I can send to you. Renee, I know you asked it, so I can send to you if I see something in the future. Okay. So we will answer, I think, a lot of these other questions as we kind of move along, so just keep listening. And if I don't answer your question, then let me know at the end. Okay, so we've been talking about changes that are going to go away for Medicare. And those are things, obviously, that providers are worried about because it will greatly change how you practice at various times. But let's talk a little bit about some changes that are staying. So these are permanent changes to Medicare that you can rely upon in the future. So first, FQHCs and RHCs can serve as distance site providers for behavioral mental telehealth services. Before the PHE, they could only serve as originating sites. So interestingly, we have a focus on behavioral and mental telehealth services for these rules that are staying around permanently. Remember, like I said, at the end of 2024, FQHCs and RHCs will no longer necessarily be able to serve as distance site providers for non-behavioral health or mental telehealth services. But permanently, FQHCs and RHCs can serve as distance site providers for behavioral and mental telehealth services. Also, Medicare beneficiaries can receive telehealth services for behavioral and mental health care in their home permanently. For behavioral and mental telehealth services, there are no geographic restrictions for the originating site, which kind of ties to the being able to provide to patients at home. Behavioral mental telehealth services can be delivered using audio-only communication platforms permanently as well. So that's definitely something to note if you provide those services. And then also rural hospital emergency departments are going to be accepted as originating sites from here moving forward. So these changes were implemented through the Physician Fee Schedules and Consolidated Appropriations Act. So this is great for the telehealth providers that provide behavioral and mental telehealth services. The idea behind making these permanent, of course, is to make sure that all patients, whether they are rural or not, can receive proper behavioral and mental health care. Hopefully, we will see additional permanent changes over the next 2 years that will add to this list. So let's talk a little bit about telehealth codes. There's some major changes to telehealth codes. These are very specific to provider type, but definitely if you have codes that you know you bill as telehealth codes right now, I recommend you check out the CMS website. They have a whole list of codes that are permanent, codes that are going to go away at a certain point, and then codes that are going to go away with the end of the PHE because they were really just meant to be temporary telehealth rules. CMS will discontinue reimbursement for audio-only evaluation and management services effective January 1st, 2024. So that one is lasting a little bit longer, but not forever. And those are CPT codes 99441 through 99443. EM services will revert to their pre-PHE bundle status under Medicare, so they will be covered but not separately payable. As a result, practitioners will no longer receive separate payments for these services, but CMS has stated that they anticipate addressing updates to Medicare telehealth services, the Medicare telehealth services list, for calendar year 2024 and beyond through their established processes as part of their physician fee schedule. So again, keep an eye out for that physician fee schedule for next year coming out sometime in November-ish. That will have a lot of updates that are important to telehealth providers. CMS, like I said, will discontinue their use of direct virtual supervision. We touched on this already, but it's important to stress that all direct supervision requirements will be reinstated on January 1st, 2024. That means that when you are documenting any service that requires direct supervision, you need to document that in-person supervision did occur after that January 1st, 2024 date. CMS is also adding 5 new permanent telehealth codes for prolonged E&M services and chronic pain management. So those are codes for prolonged inpatient or observation services by physicians or other qualified health care professionals. There's also a nursing facility one, home or residence services, chronic pain management, and an additional 15 minutes of pain management and treatment. So those are permanent additions. And CMS will extend their coverage of temporary telehealth codes until after the PHE ends. Right now, through the end of 2023, hopefully further, but right now, end of 2023 is all we have. CMS will also add 54 codes to the Category 3 telehealth list and modify their expiration to the end of 2023. So like I said, there are a ton of codes. We can't go through them all in this presentation, but if you regularly bill telehealth services, then shoot me an email if you want and I can check, or the CMS website has a whole list of these different codes and what category they go under. So we're going to switch gears here a little bit. So let's talk a little bit about DEA rules and prescribing. This is a really big deal for practices that have started instituting teleprescribing. Telemental health, of course, telepsychiatry and teleprescribing became huge practices during the pandemic and also big business. Many providers were concerned that DEA flexibilities would not be extended due to the overreach of some national telehealth companies that I won't name that were found to be improperly prescribing drugs for mental health conditions. So we kind of had some bad actors during COVID that a lot of providers were afraid would sort of ruin it for everyone. Fortunately, the DEA has come out with their temporary rules on February 24th of 2023. There was a public comment period open on these rules through March 31st. That has ended now, so we should expect to see final rules in the coming months. These new rules are expanding patient access to critical therapies beyond the scheduled end of the PHE. Many of the flexibilities are like those adopted during the PHE, but with some additional safeguards that reflect a crackdown on telehealth businesses, like I said, that were prescribing without following appropriate protocols. So these rules that the DEA has put out will not affect telemedicine consultations that do not involve prescribing controlled medications. So you can kind of not worry about it if you're not prescribing controlled medications. Then you just need to look at your state law, or by a practitioner that has previously conducted an in-person medical examination of a patient, or consultations and prescriptions by a medical practitioner that a patient is referred to if the referring practitioner was previously conducted as an in-person medical examination of the patient. That's kind of a lot of words. So essentially, you do not need to worry about the new DEA rules requiring in-person visits if you do not prescribe controlled medications. If you are a practitioner that has previously seen that patient in person, or if you were referred a patient by someone who saw that patient in person. So really what the DEA is trying to do is make sure that there's some sort of safeguards, but they're trying not to put a lot in place so that a lot of the teleprescribing that was happening during the pandemic can still keep going. The DEA rule does provide safeguards for a narrow subset of telemedicine consultations. So these include telemedicine consultations by a practitioner that has never conducted an in-person evaluation of a patient. So if you've never seen the patient before, you were not referred to that by a provider that also saw that patient, then you can prescribe controlled medication for a 30-day supply of Schedule 3 through 5 non-narcotic controlled medications, or a 30-day supply of buprenorphine for the, I can't ever pronounce that right, for the treatment of opioid use disorder without an in-person evaluation or referral. So you can only, if you are prescribing those controlled medications to a patient that you have never seen before, and that patient has also not been referred to you by someone who saw that patient in person, then you need to make sure that you're only prescribing a 30-day supply of those Schedule 3 through 5 or the buprenorphine for the treatment of the opioid use disorder. Otherwise, there is no safeguard for the prescribing of Schedule 1 or 2 drugs. So after May 11th, 2023, a patient will need to have an in-person visit prior to being able to receive Schedule 1 or 2 drugs via telehealth. I will say this directly conflicts with some state law that was recently put out about teleprescribing. The DEA is going to override state law in many cases. So just after May 11th, 2023, if you regularly prescribe Schedule 1 or 2 drugs to patients that you have never seen before, then you may need to revamp a little bit of your procedure or make sure that that patient is receiving an in-person visit from their PCP or someone else before they come to see you for teleprescribing. So HIPAA is another, we had a lot of HIPAA waivers during the PHE, so that's something else that we need to worry about. Because telehealth appointments had to be implemented so quickly, of course, the beginning of the PHE, the OCR used its enforcement discretion to allow providers to use telehealth in good faith, even when their platforms or software were not HIPAA compliant. However, this enforcement discretion only remains in effect until the end of the PHE, again, May 11, 2023. So at that point, you need to make sure that you're using HIPAA secure, BAA-covered video platforms and patient communication tools. Also important is that the OCR will resume enforcing penalties on providers for non-compliance with these rules when the PHE ends. So if you are using, Facebook video, or you're using some other sort of non-HIPAA compliant platform to talk to your patients, then by May 11th, you need to make sure that you're switching over to a HIPAA compliance platform. Of course, we always recommend, if you have some sort of video platform service that you're using and they refuse to sign a BAA, then don't use them, because as a covered provider, you need to make sure that you are keeping your patient information confidential, and using the business associate agreements is one way that you can make sure that you are doing that. So let's talk a little bit about documentation requirements and tips, since of course the rules are changing so much and enforcement will be back with a vengeance. It's important to make sure that you're reviewing your documentation procedures so that you can comply with any new requirements that are upcoming, and also make sure that your staff know when the various rules are ending and when you need to put new policies in place. Documenting, of course, is just as important in telehealth as it is in face-to-face visits. This is your first defense to any sort of malpractice or fraud and abuse claims. Reporting if the visit took place by video and audio or just audio is essential, because that will dictate your payment, and sometimes if payment is allowed. Good notes definitely should include the reason for the visit, discussion of the visit, assessment of evaluation, and any sort of plan. In addition, it should be documented who provided the service and how the patient consented. Your state laws will often have consent requirements in their telehealth laws. Ohio does. We'll talk about that in a few minutes. So make sure that you are documenting if the patient consented via a written consent or verbally. Medicare also added over 100 CPT and HCPCS codes for the duration of the PHE. So make sure you understand which codes you need to use and when to use them, because of course using the wrong code can delay payment. And ensure reimbursement by staying up to date also on the latest codes. Like I said, CMS has a list of them, so you can double check when these codes will be active. Post-visit, document as thoroughly as possible to ensure reimbursement. So definitely keep in mind the consent, make a note for verbal or written consent. Telephone codes are required for audio-only appointments, while office codes can be used for audio and video visits, so make sure you have your right code category. Many states require a telehealth visit be done in real time, so they may not allow store and forward activities anymore moving forward. That will depend on your state law. And then also during the PHE, we had an expansion of the definition of originating sites and distant sites under telehealth. So make sure that you are properly documenting where you are and where the patient is, so that you can be sure that you're adding the right modifiers and indicating what the correct originating and distant site is. And also, just as required with in-person face-to-face visits, telehealth visits need to meet medical necessity in documentation. Documentation needs to establish a chief complaint warranting the medical evaluations, description of discussion, and prescriptions or orders. Generally, the same template can be used for an in-person encounter that can be used for a telehealth encounter. These are things that you should already have implemented, but if you don't, it's definitely time to do that because enforcement is coming down soon. So some general guidelines, you should be receiving informed consent for your telehealth services, educate patients about the unique risks of a telehealth visit before getting their consent, make sure to include that there is a potential for technical difficulties, security concerns, and that there is a potential chance for converting the visit to an in-person visit based on the patient's needs. And also in the documentation, ensure to include a summary of the discussion if you have one and the patient's decision. Some states require you to get informed consent for telehealth every time that you meet with a patient, and some do not. So just check on your state laws there. The mode of telehealth, make sure that you say whether you are using audio only or audio and video. You can also put something like secure interactive audio video session using Skype or medication management visit conducted by telephone or something like that. Make sure you're confirming the identity of your patients. They can hold up their photo ID or have some sort of PIN that you can put in to make sure that the patient is who they say they are. Also, record the patient's location, their physical location. So for example, are they at their home in Ohio? Are they at their home in Nebraska? You know, any of those sorts of things. And then also appropriateness. Quickly determine at the beginning of a telehealth visit if telehealth is the appropriate way to conduct this visit. Is there something happening with the patient that indicates that they would be better served at an in-person visit, or is telehealth going to be able to fulfill all of the same requirements that an in-person visit would? And then make sure to include all participants in the documentation. So if there is someone like a parent or a spouse participating in the conversation via telehealth, record their names as well as anyone else who is there. And if the patient, you know, isn't in a place where they feel safe talking about whatever medical concerns they have, then perhaps that is a reason that you need to reschedule so that the patient can be located somewhere where they feel more comfortable. And then also plan in advance and provide instruction for patient assistance. So for patients who might be obtaining their own vital signs or patients who just have technical difficulties, make sure you have plans and policies in place for those. So consent, like I said, is going to be based on your state law. It's hopefully something that you have been doing for a long time, but make sure that you are checking each state that will have its own laws regarding provider licensing, patient consent, and online prescribing. We'll talk about Ohio's in just a second. 38 states and DC require providers to obtain and document patients' informed consent before a telehealth visit. In some states, that applies to only Medicaid beneficiaries, but in others, it will apply to all payers. In most states, verbal consent is permitted, but sometimes in the minority written consent, that's really only a couple of states. Due to the PHE, some states that did require written consent have waived it. So for example, Alabama, Delaware, Georgia, and Maine allowed verbal consent for the PHE. However, they may be ending it soon, so make sure that you are checking on those. And just some notes about consent, because it is very important to make sure that you are complying moving on in the future without any of these waivers. When you're meeting with a patient, explain what they may expect from the telehealth visit and what rights they have. Most people, I would guess, would be familiar with these by now, but you should never assume that patients know your expectations. Ensure the patient knows their responsibilities during any sort of online counseling or tele-behavioral visits. You can suggest specific steps like wearing headphones or finding a place to be alone. Tell the patient and get their consent at the start if anyone is observing the visit, and ask if the patient is in a space where they are alone or if they want to be alone. Ensure patients complete any required forms beforehand and bring them to their visit or submit them through your portal. You know, make sure you have HIPAA compliant ways for patients to get you their forms. And then also complete or receive the informed consent and other compliance documentation during check-in, including verbal consent. So just make sure that you're kind of crossing those off every time you have a visit, depending on what your policies require you to do. So let's talk a little bit about Ohio's new telehealth rules. I'm located in Ohio, so this is what I'm most familiar with. If you have questions about other states, I can certainly help you connect to those rules. So after a long wait, on Tuesday, February 21st, 2023, the State Medical Board of Ohio finally released its telehealth rules to implement Ohio's telehealth statute, which is ORC 474309. That statute has been around for a little while, but we were just waiting for the rules. So these rules apply to physicians, physician assistants, dietitians, respiratory care professionals, and genetic counselors. Ohio's advanced practice registered nurses, or APRNs, should also take note of these rules. Technically, APRNs are governed by the Board of Nursing, but because they collaborate with physicians and have standard care arrangements, they will still be affected by the scope of practice of their collaborating physicians. So the general telehealth provisions from this Board of Medicine rule, it applies to Ohio patients only. So if you are a provider and you are providing telehealth services to patients located outside of Ohio, then you need to follow those state rules. There were a lot of waivers during the PHE allowing providers to kind of practice in between state lines. A lot of those were actually finalized in many states, but you need to make sure that if you are an Ohio provider, but you are providing telehealth services to someone in Tennessee, that the Tennessee law does not require you to do anything specific or to be licensed in that state, for example, in order to provide those services. The same standard of care applies to both telehealth and in-person visits. This is pretty standard across board, not just specific to Ohio, but you need to make sure that when you're doing telehealth, it lives up to the same standards as an in-person visit. If the same standard of care as an in-person visit can be met, then providers may use synchronous or asynchronous technology. So this means you can, in Ohio, use store and forward technology, or you can use a phone or Skype or any of those audio and video elements. The rules provide direction on when an in-person visit or referral of the patient to another provider is required. So essentially, if a telehealth visit will not allow for the practitioner to properly evaluate or treat the patient, then the patient must be referred to an in-person visit. I would say this is pretty standard across states as well. In certain circumstances, formal consultations with another healthcare provider are required, and those are going to be dictated by the acuity of the patient and, if there's some sort of emergent or immediate need. If the patient consents, physicians and physician assistants may provide telehealth services through FDA-approved remote monitoring devices. That is not necessarily true in every state, but is allowed in Ohio. And also, the rules set forth the requirements for a physician or physician assistant to prescribe, personally furnished, or otherwise provide a non-controlled prescription through telehealth. And we will get to controlled prescribing here on the next slide. So just as a summary for physicians or anyone enrolled by the Board of Medicine in Ohio, pretty standard. You can, as long as you can fulfill that in-person standard of care parity, then you can provide a huge range of telehealth services. So what about controlled substances? Ohio's new law regarding controlled substances prescribed via telehealth requires a physician or physician assistant who holds a valid prescriber number, and again, this will also apply to APRNs, and who has been granted prescriptive authority to comply with federal law requirements when prescribing, personally furnishing, or otherwise providing controlled prescription drugs. This is important because it means that the DEA rule that we talked about earlier, where if you're prescribing Schedule 1 or 2 drugs, you need to have an in-person visit following the end of the PHE, that is going to override anything else that's in the Ohio rules. A physician exam must be done prior to prescribing a Schedule 2 drug to new patients unless one of the following requirements is met. So we have some exceptions in Ohio. If there's a new patient receiving hospice or palliative care, substance use disorder patient being treated through FDA-approved medication, treatment, assisted treatment, or for opioid use disorder, if the drug is prescribed to treat a mental health condition, if the patient is in an emergency situation, or if the prescribing of a controlled substance through the telehealth services is being done under an exception permitted by federal law governing prescription drugs that are controlled substances. I want to talk about that one for a second. So you can see here there's going to be, following the end of the PHE, a direct conflict between what the DEA is requiring and what Ohio is requiring, because Ohio's law is a little bit wider as far as scheduling As far as prescribing Schedule II drugs to new patients, there's a couple more exceptions under Ohio law. So make sure federal law will overrule this in most cases. But there is this last exception here, prescribing of controlled substances being done through an exception permitted by federal law. The DEA does have the power to create a list of providers, essentially, that can provide these controlled substances without the in-person requirement. That has existed for many years, but the DEA has just never followed through with doing that. So now there's a really big push as the DEA is considering what rules it's going to make permanent and what it's going to finalize to actually do that, create an exception so that there can be some providers who are able to provide Schedule I and II drugs to new patients without having to see them in person. So we'll have to hang tight and see if that actually happens, but that is something that is being pushed for right now. So for behavioral health providers who are licensed and provide services under the Ohio Mental Health and Addiction Services Department, there is a separate telehealth rule that was made permanent in July 2022. These rules state that no initial in-person visit is necessary to initiate services using telehealth modalities. The decision of whether or not to provide initial or occasional in-person sessions can be based on client choice, appropriate clinical decision-making, and professional responsibility, including the requirements of whatever licensure board you may fall under. The services that can be provided under this, under OMAS for telehealth are general mental health services, CPST, therapeutic behavioral services, psychosocial rehab services, peer recovery, SUD, crisis intervention. Pretty much anything that can be licensed under OMAS or credentialed under OMAS can be provided via telehealth. Individuals receiving residential and withdrawal management substance use disorder services or mental health day treatment services can receive any of those component services that I just listed through telehealth, even though their residential services, of course, are in person. Progress notes must include documentation to reflect that the service was provided via telehealth, and also remember to add consent documentation. Providers and facilities must have a written policy and procedure describing how they ensure that staff assisting clients with telehealth services are adequately trained in equipment usage. So that's a little bit different. Prior to providing telehealth services, the provider has to describe to the client the potential risks. So this is getting back to consent, as well as document that the client was provided with the risks and agreed to assume those risks. And also, providers must have a contingency plan for providing services to clients when technical problems occur, and a list of local resources for where the client resides in case the client is in crisis. Those local resources include a suicide prevention line and also local 911 services. Providers must also, of course, follow all confidentiality requirements under state and federal law. And this is key here for our OMAS rules. Provider must have a physical location in Ohio or have access to a physical location in Ohio where individuals may opt to receive in-person services rather than telehealth services. So if you are a provider just outside of Ohio, for example, in Indiana or Kentucky, and you want to provide these telemental health services under OMAS, then you need to either have a physical location in Ohio for those patients that you're treating in Ohio, or make sure that there's somewhere that those patients can go that you are affiliated with, where those patients can receive in-person services rather than telehealth services if they need to. That's kind of a unique one for Ohio. And finally, the Ohio Medicaid rule was an emergency rule at the beginning of the PHE and then was permanently put in place about a year ago. So the Ohio Medicaid rule allows for synchronous and asynchronous forms of communication. So again, pretty broad. Providers have a responsibility to deliver telehealth services in accordance with HIPAA and maintain documentation, of course, as required. For any practitioners who render services to individuals for a period longer than 12 consecutive months, the telehealth practice or practitioner is expected to conduct at least one in-person annual visit or refer the individual to someone that is not in an emergency department for an in-person annual visit. So Ohio Medicaid is requiring its providers to either see a telehealth-only patient at least once a year or refer that patient to someone who they can see in person once a year. Also, there are specific services listed in this rule that are eligible for payment when provided via telehealth, which is a huge variety of services for new and established patients, including PT, OT, and speech, and hospice, audiology, all kinds of things. And also, unless stated otherwise in the billing guidelines, professional claims submitted for healthcare services provided through the use of telehealth to Ohio Medicaid need to include a GT modifier, a place of service code that reflects the physical location of the treating practitioner at the time a healthcare service is provided. And then there's also another modifier if the physical location of the patient is the patient's home, a school, inpatient hospital, outpatient hospital, nursing facility, or intermediate care facility for individuals with intellectual disabilities. So if you are an Ohio Medicaid provider, make sure that you are paying attention to this rule and looking at the various services that are allowed to be provided, as well as any modifiers that you might need. And I know there was a question about place of service that I will look at in a second, but for this, for Ohio Medicaid at least, you need to have the place of service that reflects the physical location of the treating practitioner at the time of the telehealth appointment. Okay, so let's look at our questions here. Okay, so we talked a little bit about prescribing medications and billing issues. If you're prescribing across state lines, so say we're only doing non-controlled medications, we're not worried about the controlled medications. If you're prescribing across state lines, then you need to look at the Board of Pharmacy rules in the state where the patient is residing, because that is where they're going to have to get the medications, and that's where the prescription needs to be valid. So make sure that you are looking at that other state and seeing if your prescriptions will apply there. Are there any requirements or an office in another state other than the state you're physically located? So I think this question is asking, do you have to have a physical location in another state if you're prescribing or treating someone across state lines? Not necessarily. The only requirement that I've seen about that is that Ohio Mental Health and Addiction Services rule, where you do have to make sure that the patient has access at least to a physical office. So depending on what kind of provider you are, then you just need to double check and make sure that that is not something that you need to comply with. So can you review what needs to be written on a telehealth script for a non-controlled med, if anything? So your requirements for what you need to write on scripts are going to be per state law. I know that's an annoying answer, but it is true. So if you're prescribing in Ohio, then you need to look at Ohio's Board of Pharmacy and see what their requirements are. You should indicate that, a service was provided via telehealth. Whether that is in the note or on the script is going to depend on the requirements of the Board of Pharmacy, but it's never a bad idea to include that information. Is there a requirement for direct supervision for pathology labs? That will expire. So I'm not sure off the top of my head for pathology labs specifically, but I can look into that for you. If you want to email me directly, then I can see if there is anything out there. There are a ton of rules from Medicare that are going to be expiring that we couldn't cover today, so it's very possible there's something specific to pathology labs. Okay, so after 12/31/23, you cannot see any new patients via telehealth. Not necessarily. So it really just depends on what services you're providing. You should be able to see new patients via telehealth in a lot of situations. You may not be able to prescribe to new patients necessarily sometimes, but it's really just going to depend on what services you're providing and what payer, because Medicare, some flexibilities are going to end on May 11th, some are going to end at the end of this year, some are going to end at 2024. If you don't care about Medicare, then you need to look at the payers you do care about, because they will have their own policies. So place of service after the PHE is over. Commercial insurance, you're going to have to check those individually to see if they have any requirements for place of service. For Medicare, I believe it is similar to Ohio, which is where the provider is located. So that may be specific to the services you're providing, but generally that has been the case, I think, moving forward. Okay, so prescribing, this is a question about prescribing controlled medications via telehealth for new patients for 30 days, even if you have not seen them. as long as that is okay with your state law, then that is what the new DEA rule is saying. But you need to make sure that they are Schedule 3 through 5 or the opioid use disorder medication for 30 days. You need to make sure that they are not Schedule 1 or 2 substances, because those cannot be provided without an inpatient visit. Another question, if you prescribe in another state and you have a DEA in another state, do you also have to have an actual office in the other state? Okay, so this is kind of there's a lot of factors to this question that's going to be individual to the types of services that you're providing. The DEA requires you to have licenses in where you are located. So you are allowed to prescribe. The DEA is not necessarily saying that you can't prescribe across state lines, but they are dictating what you can prescribe without having seen the patient. So for example, if you're a national telehealth prescriber and you have patients in all kinds of states, then you may need to create relationships with providers in individual states to see those patients, or at least have a way for the patient to be referred to you from a provider they already see. So for example, we have some clients who are looking into what they're going to do about this and saying, okay, well, we have patients in Nebraska, but we don't have any providers in Nebraska, so we're going to change our policy once the PHE ends to be that the patient has to see their primary care physician within a certain amount of time before getting our services via telehealth. There are people advocating to change that rule and get the DEA to change it when they issue the final rules, but that hasn't happened yet. So right now, just be aware of what the proposed rules are, which is that you are going to have that inpatient visit first if you're prescribing Schedule 1 or 2 substances via telehealth through the DEA. But we haven't had the final rules issued yet. So keep an eye out in the coming months to see if those final rules change anything. And of course, you can always advocate in the interim to see if you can influence the DEA and how they are going to issue those final rules. And then if you are licensed in the state in which you live and practice and the state your patient is in, do you provide both licenses for the non-controlled drug, or which one? Okay, so if you're licensed in the state in which you live and practice and the state your patient is, okay. So if you are licensed in 2 states, you're licensed in the state where you are and the state where your patient is, then you're prescribing, the rules for prescribing are going to be where the patient is. And also, if the patient if you're located in Ohio, patient's located in Illinois, and you're going to bill Illinois Medicaid, then you need to look at those Illinois Medicaid rules. So I hope that makes sense. Okay, I think that's all the questions that I see, and we are right at time. So I will stick around for another minute, but thank you so much for attending. I hope it was helpful. Please feel free to email me with questions. And attend our future webinars about the PHE. We'll have a lot more coming to you.